everybody. Welcome back to another episode of Hybrid Healing Hour. Today, we are going to be talking about sleep apnea, part 2. So we're going to be looking at sleep apnea in a different perspective with our special guest, Dr. Ken Wojnowski. Hello, Ken.
Hi, how are you?
Good. How are you doing?
Doing great. Thanks for having me.
Yes. And I would love for you to tell our audience a little bit about yourself and how you got to where you are today.
Sure. So I am a current pulmonary and critical care fellow at Bay State Medical Center, which is a University of Massachusetts affiliate in Springfield, Massachusetts. Prior to my current fellowship, I completed a sleep medicine fellowship at the University of Miami. So I hold board certifications in internal medicine, pulmonary, and sleep medicine, and I'll be sitting for my critical care boards in November.
Wow.
So are most sleep specialists pulmonary, or are there other type of sleep specialists as well?
You can do a sleep medicine fellowship from many different medical specialties. Traditionally, they have been out of pulmonary and neurology, but you can also do it straight from internal medicine, family medicine, and even anesthesia, as well as psychiatry. So you can do it from many different routes.
And I think it's interesting because I don't think most people realize that sleep falls under a respiratory field, right? Nobody thinks of it as respiratory. They think of sleep as neurological or even psychiatric.
Yeah.
Right. I think the vast majority of people that we see in the sleep clinic have sleep apnea, which we think about as a respiratory problem, but insomnia is a huge problem, as well as other medical issues that usually we think about in the realm of neurology and psychiatry.
So what drew you to this field?
A few different things. Number one is I needed a 1-year placeholder while my wife and I could get on the same schedule to apply for fellowship. But my father had sleep apnea, and it really seemed to change his life once he was diagnosed and he started using his CPAP device. So that's another reason why I was drawn to the field. And I also thought it could make me a better, more well-rounded pulmonologist. And it also could help me in my application process.
Excellent.
I mean, as we know, sleep apnea is associated with many different diagnoses and other conditions. What do you often see most in your care?
So patients with sleep apnea, they have a lot of cardiovascular comorbidities. So things like atrial fibrillation, persistent hypertension that's difficult to treat, stroke, heart attack, myocardial infarction. Those are most of the major comorbidities that we see in patients with sleep apnea.
Do you see a relation with diabetes?
Yes, we do. So poor sleep in general, so fragmented sleep can cause impaired fasting blood glucose levels and can worsen type 2 diabetes and just have a lot harder to control blood sugars. So sleep apnea certainly is a huge component of that.
So you talked about the fragmented sleep. So assuming that people with sleep apnea are not getting a thorough, good night's rest. So can you go ahead and tell us a little bit about the different types of sleep apnea?
Sure. So basically we have obstructive sleep apnea, which comprises the majority of patients with sleep apnea. That's a repetitive and reversible upper airway closure during sleep, which can lead to decreased oxygen saturations as well as arousals from sleep. So you have really fragmented sleep. The other type of sleep apnea is central sleep apnea. Those are mostly associated with other medical issues as the primary root cause. We see it very commonly in patients with heart failure, patients with a prior history of stroke, and maybe on patients who are on chronic opiates for pain management.
And snoring doesn't always correlate with sleep apnea, right? I mean, you can have sleep apnea and not snore, and you can snore and not have sleep apnea.
Correct. So not all snorers have sleep apnea. Actually, the most common finding in patients that will later have obstructive sleep apnea is having a spouse that is concerned for your breathing at nighttime. So if you see someone in the clinic and the spouse is there and they say, "Oh my goodness, I wake him up in the middle of the night because I feel like he stops breathing," that's actually one of the most important indicators that someone has sleep apnea.
And neck circumference, collar size, is that correlated?
I usually think around 16 and a half inches or more for men and 15 and a half inches or more for women as a cutoff. That will vary within person-to-person range, but usually I think of maybe 15 and a half inches or more.
And there's something also called the Mallampati score, right, that anesthesiologists use. You want to explain that?
Correct. So Mallampati score is from 1 to 4, 1 obviously being the least crowded oropharynx and 4 being the most crowded oropharynx. Basically, if you were asked to ask your patient to open their mouth and if you can see their uvula, that would be a 1. If you see part of the uvula, it would be 2. If you barely see the top of the uvula, it would be 3. And if you don't see anything in the upper airway at all, that's a Mallampati score of 4. So
and the uvula is the dangly ball in the back of your throat for those listening.
Correct. So Mallampati 3 and 4 are associated with having a higher risk for sleep apnea. Mallampati 1 or 2 are not really associated with sleep apnea. So
interesting. Now, how do you diagnose sleep apnea?
So sleep testing is important, okay? A lot of times nowadays, insurance companies will push patients to get a portable sleep apnea test, which is something that you can do in your home. Basically what it is, it's a lead that goes around your chest to detect respiratory effort, a sensor on your finger to detect oxygen saturation, and then a heart rate monitor, okay? It will also have a microphone to detect snoring. It has a sensitivity about 80% in patients with obstructive sleep apnea. It seems to work really well in diagnosing patients who are obese, who are males, who snore and have hypertension. So if you're sort of the atypical person for obstructive sleep apnea, if you're thin, if you don't have much snoring, but you're just having really poor restless sleep, a portable sleep study is probably not the best test. The best test would be an in-lab sleep study, which has a little more bells and whistles. There's a lot more connections and things, but you are monitored overnight in the laboratory with a sleep technologist who's watching you to see if there are any issues that need to be addressed.
But, okay, let's be real. How can anybody fall asleep in one of those sleep labs with all of those wires connected? I've seen where a patient took a selfie, a picture of them, and they showed it to me, and they were in a gown. It had the box like holding, like an EKG or whatever, and all these wires. And then they're told to go to sleep on their time. The lights go out, and they get woken up at like 3 or 4 in the morning and say, okay, leave. You got to get out of here. We got to get the next run ready.
Correct. So
I'm like, what?
It's not a perfect test. There's obviously a lot of things that go into it. If you let someone sleep in the lab for 3 nights in a row, that third night would probably be the best test because they're finally used to their scenario and they're used to their surroundings. But the issue is cost. It's a fairly costly test, which is why we would like to do portable sleep testing in the home, which also may be more beneficial for patients who have issues sleeping in a setting that's not their own, or maybe even shift workers. So if I had someone who was on the night shift, had trouble switching back and forth, that's not someone who's appropriate for an in-lab sleep test. That's someone we can test in the home where they can sleep during their usual daytime sleep hours.
Right.
And do you tell people if they're going to do a sleep study to take their usual sleeping medicines or anything else they take?
I would not change anything that you're doing. Whatever you do at home is the routine that I would try to continue during your sleep test because we want to know where you are in your usual daily routine. So I would continue to take medications as you would at home.
Does alcohol affect sleep apnea?
Alcohol does, and it mostly has to do with its muscle relaxant properties. So the pathophysiology behind obstructive sleep apnea is that you have muscles in your upper airway that their sole job is to splint the airway open, okay? So when those muscles contract, your trachea and your upper airway opens. At nighttime when we sleep, especially during REM sleep, our muscles become atonic or they become more relaxed. So those muscles where their only job is to keep the upper airway open, they become more relaxed, your airway closes, and that's what causes obstructive sleep apnea. So alcohol will make obstructive sleep apnea worse, mostly due to its muscle relaxant properties.
And is there any nasal component to sleep apnea?
Yes, although the airway obstruction is a little lower, but you can have upper airway resistance syndrome, which is a sort of a spectrum of sleep disordered breathing that's related to obstructive sleep apnea. They are related.
Okay.
Wow. So I would say let's dive into certain symptoms of sleep apnea and, long-term risks of untreated sleep apnea.
Sure. So patients with untreated obstructive sleep apnea, one of the most common things was that they'll be sleepy. So we have a score that we use in the clinic called the Epworth Sleepiness Scale, which asks a series of 8 questions in scenarios in which patients may have unintended sleep, such as waiting in your doctor's office, waiting to be called for your appointment. Mm-hmm. Would you fall asleep after lunch if you had some time to lay down? Have you ever fallen asleep in conversation? Would you fall asleep as a passenger in a car? So that score is out of 20. Most people with a score of 10 or more have what we call physiologic sleepiness, and they're at risk for having obstructive sleep apnea. Other common symptoms are morning headache. So patients with obstructive sleep apnea, they wake up with headaches. And another thing which is fairly common that you might see in the primary care clinic is nocturia. So
nighttime urination.
Correct. So when you have obstructive sleep apnea, it actually causes the release of atrial natriuretic peptides from the heart wall muscle, which causes diuresis. So these patients will wake up 2 to 3 times per night, and it may not be due to BPH.
That's very interesting.
It may be due to obstructive sleep apnea.
And we say BPH, we mean benign prostatic hyperplasia,
Correct.
or like for men, like an enlarged prostate with aging, right?
So when you think of an 80-year-old man going to the bathroom a few times per night, we think that's normal because their prostate's probably enlarged, but they may have sleep apnea.
Very interesting. And I like how you already touched on, resistant blood pressure as well. That's always a telltale sign. When I see that, I'm like, you should be tested for this. Now, how do you approach the patient who you highly suggest that they have sleep apnea, but they don't want to be tested because they don't want to use a CPAP?
That's a great question. I would always say that let's test and see how severe the problem is first, because different severities of sleep apnea can be treated differently. We don't necessarily need to rush to CPAP if someone has mild or moderate obstructive sleep apnea. And the other thing too is when we prescribe CPAP to someone, there are many different things that we can try in order to get someone used to and get someone accommodated to their CPAP device. So I would always encourage the patients to try because they may feel better. I've had patients who, have such severe fatigue and sleepiness during the day, and they tried their CPAP and it's really uncomfortable for them. And my first visit in the clinic with them is a lot of anger. But we make a few minor adjustments and we get them to use their CPAP, and they really do enjoy it afterwards. So you'll have to make adjustments. It won't be just a one size fits all.
We're at a time now where we have so many different choices, right? It's different types of machines, different size machines, humidifiers, different types of masks. I think that's the biggest problem is patients sometimes don't just give it long enough and they're not offered different choices.
So there was a recent study, I think in the Annals of the American Thoracic Society, which looked at full face masks, so a CPAP mask that goes above your nose and over your mouth versus just a nasal interface. And it actually found that full face masks cause an auto CPAP machine to use higher pressures on each patient, which will actually cause decreased adherence down the road. So they actually recommend nasal interfaces over full face masks, which is a big problem because a lot of times we're referring out to DME companies or durable medical equipment companies who are giving patients the mask, and we really have no say as physicians as to which mask they get.
Right.
But I usually like to tell people about there are websites that have hundreds of different kinds of masks, and I encourage them to try to buy one and see if it's more useful for them.
But now, would the nasal pillows dry out the nasal passageways?
So it can, and a lot of times you'll have patients say, well, I'm a mouth breather, so how would a nasal mask work for you?
Right.
There's something called a chin strap as well that you can use to close the mouth so that patients are almost forced to breathe through their nose. And nasal dryness can be helped by humidification or with some nasal sprays. You can use saline nasal sprays prior to the use of your nasal mask as well. But I would always recommend starting off with a humidifier. All these CPAP devices come with humidification. You just have to fill it with distilled water prior to use. And I would recommend all patients use that.
So let's back up a little bit because we started talking about CPAP, but we didn't really explain what CPAP is.
That's true.
So why don't you
I got
explain
excited.
exactly what it stands for and what it is?
So CPAP stands for continuous positive airway pressure, which essentially works as a pneumatic splint during the nighttime to keep your upper airway open so that you don't have these respiratory events that cause frequent awakenings and desaturations, oxygen desaturations. And
there's auto CPAPs and CPAPs where the pressure is set.
Correct. So a lot of times in the clinic, what we'll do is we'll prescribe an auto-titrating positive airway pressure device, which is basically an auto CPAP. The doctor sets a low and a high range, and the CPAP device will see how you're breathing, and it will automatically adjust how much pressure you need. A lot of times during REM sleep, so in the early morning hours, like 3 to 5 a.m., where our muscles are most relaxed, you'll have more upper airway collapse. So you may need a higher pressure during REM sleep than you would at the beginning of the night when you're not in as deep of sleep. So these auto-titrating positive airway pressure devices will manually adjust it based on the patient's breathing. Now, fixed CPAP is just one set level. So you can use 8 centimeters of water or 10 centimeters of water. A lot of times what I do is I'll put a patient on an auto-titrating device and I'll look at how much they spend, if they spend 90% of the night at a CPAP pressure of 10, then I'll switch it back to a fixed pressure of 10 so that we're just keeping them at the same pressure. It's all a matter of preference, and there are no difference in outcomes between auto-titrating CPAP and a fixed CPAP pressure.
I always like the auto CPAPs in our practice because we have so many patients who are doing weight loss on, and as they lose weight, their pressure may change, and rather than having to go get the machine recalibrated, sometimes it's easier for them.
And using an auto-titrating device also it helps us keep the patients out of the lab. So you don't have to do a CPAP titration study if they have relatively simple OSA, and you can do auto-titrating positive airway pressure.
And can you explain what BiPAP is and how BiPAP differs?
BiPAP uses an inspiratory pressure and an expiratory pressure. So usually a BiPAP machine will deliver a higher pressure when you breathe in and a lower pressure when you breathe out. This is used a lot of times in patients with COPD who have trouble breathing at nighttime and who need a little extra ventilation to take bigger breaths at nighttime. CPAP is a fixed pressure during inspiration and expiration.
Does body habitus matter on whether they get a CPAP or a BiPAP?
No, we usually use CPAP for most cases of obstructive sleep apnea. If they have a little more complex OSA or they need help with transcutaneous carbon dioxide, which is a measure of ventilation at nighttime, if that starts to rise during an in-lab study, you can use BiPAP. Very
interesting. All right.
And do you know anything about like the biometric devices that people use now, the Oura Rings and the Apple Watches? Is there any data on that someone can see themselves that may clue them in that they may have a problem?
So the only thing I would caution patients about this is I wouldn't diagnose obstructive sleep apnea based on something from an Oura Ring or an Apple Watch, but it's something that can be used as a clue-in for a patient to be evaluated by a physician to see if they do have a sleep issue. So a lot of times patients will come to me with their list of printouts, and it'll just be my trigger to do a confirmatory test, whether by a portable sleep testing or an in-lab sleep study. I think it's very useful, especially if you have patients who are in tune with their bodies and they know something's wrong. It may just be an early identifier that there's an issue at nighttime.
Yeah.
Can you actually talk a little bit about how the machines nowadays, like the CPAP and the BiPAP machines, actually give data as well?
Right.
My thing is, I never get a chance to see the data as a clinician, and I would like to, but I think that a lot of my patients don't know how that quite works.
Sure.
Do you have any tips?
So the patients can follow along on the app, and they can see if they're having residual events. We classify sleep apnea by the apnea-hypopnea index, so mild to moderate. Mild OSA is 5 to 15 respiratory events per hour at nighttime.
And do you usually treat that if it's mild?
You can if you have symptoms, and you should if you have symptoms. If patients are completely asymptomatic and they have mild OSA, there's no indication to treat. Moderate OSA is 15 to 30 events per hour, and then severe sleep apnea is greater than 30 events per hour. So the patient will have an app, and they'll see their residual AHI, which means how many respiratory events am I still having when they're using their CPAP. And the patients will also get a report on how large their mask leak is, so that if they're having a lot of leak of air throughout their mask, that's something that needs to be addressed. As a physician or a provider, you'll have you can get much more greater detail. Okay, you'll have the total time spent with a certain CPAP pressure. That'll be like your 90th percentile CPAP pressure. You'll get other things like how many hours per night it was used and things like that. But you might have to go through the supplier.
That's what I was wondering, if that's how we would have to do it. Okay.
Yeah. So the two major suppliers, it was Philips before they started to have some issues, and ResMed as well.
Yeah, we do a lot of ResMed.
Yeah, so ResMed has a website that you might be able to just contact and say, hey, I prescribe your devices all the time. Can I please have an account?
Oh, that'd be great. Mm-hmm. Now, I wanted to ask, what about, I guess, when is it recommended to change out the device or the tubing or to clean it? Like, what's the maintenance with like a CPAP machine?
Yeah, so usually every few months. I think if you're using the same mask for 6 months, it's too long. And then we usually will change out the humidified tubing every few months as well. So usually 3 to 6 months, we'd like to change those out.
Okay.
The machines will last for a few years. So I think if you're using your machine for closer to 5 years, we would recommend switching to a new device.
I'm sure technology is always changing.
Right. Mm-hmm.
How do you recommend patients clean?
Soap and water. Okay. There's been a lot of issues with something called SoClean device. That's why Philips had their major recall, is that patients were using a SoClean ozone cleaning device for their machine, and it was causing breakdown of a certain particle. So I would just recommend cleaning your tubing and your mask with soap and water.
Okay.
So are there any newer treatments for sleep apnea other than CPAP or BiPAP?
Yeah, so I think we can start with the most mild sleep apnea, how I would treat that in the clinic. So and there are certain other classifications of sleep apnea as well. So our sleep testing will tell you if your sleep apnea is worse in the supine position or lying flat on your back, or if it's consistent in the supine on your side or on your stomach. So patients who have more severe sleep apnea when they're lying flat on their back, we would just recommend a positional device so that they avoid sleeping on their back. That could be the easiest solution. Obviously, there's a huge association with weight and obstructive sleep apnea. So weight loss and exercise is something I recommend to all patients. Mandibular advancement devices are useful for patients with mild to moderate sleep apnea. In the past, they have done surgeries like a UPPP or a uvulopalatal pharyngeoplasty.
Very, very painful surgery. And
Painful surgery.
How effective is it?
About 50% effective and a prolonged recovery. So we don't do that much anymore. There is something called an Inspire device or a hypoglossal nerve stimulator. You have to meet a certain set of criteria. Okay, traditionally it was you have to have a BMI or a body mass index less than 32. You have to have an apnea-hypopnea index of 15 to 65. The Inspire device was not studied in patients with mild obstructive sleep apnea or in patients with an AHI greater than 65. So it's not applied to those patients. And then you also have to go through something called a DISE, a D-I-S-E, a drug-induced sleep endoscopy, to see how your airway collapses. If your airway collapses a certain way, you may not be a candidate for the Inspire device. And you have had to have tried CPAP and either been intolerant to, or it didn't do the job that it was supposed to. So you have to meet a certain set of criteria to qualify for the Inspire device.
Wow. And then there's, I guess, is there any new ones on the horizon? Any other new treatment options out there?
So we're starting now in the age of tirzepatide, we're starting to study weight loss drugs more. And the tirzepatide has been found to reduce the apnea-hypopnea index in patients with obesity and obstructive sleep apnea. There are some other medications that are being looked at that have shown promise, perhaps as an adjunct to CPAP, not necessarily as a solo treatment. And for central sleep apnea specifically, there is a phrenic nerve stimulator that's been looked at. So there are things that are constantly being looked at. But I think the pharmaceutical industry is very interesting.
And nowadays, I feel like there's so many different beds. I think I'm blanking on the name of one, but
8 Sleep.
8 Sleep, is it? Yeah, they can like automatically raise your head.
It senses that you're snoring.
Exactly. There's like AI and
That's just for snoring.
right. It's just for snoring, assuming, right? But
I think the reality is most patients with obstructive sleep apnea will snore, but not all snorers have OSA.
Right. Yeah. And I mean, and actually that was going to be my next question is like, what about myths? Like, what are some things that maybe people out there think, it might be associated with sleep apnea and it's not, or vice versa? I don't know if you can think of any, but I know like snoring is one of them, right? Just because you snore doesn't mean you have sleep apnea and vice versa. But I also know like not everybody who has sleep apnea is overweight.
Correct. So you don't have to be obese to have obstructive sleep apnea. Patients have jaw anatomy that's slightly different than each other. So you may have more crowding in the upper airway than another person. So that is a myth. Another myth is that, let's say you go through bariatric surgery and you lose all of your weight. It may not actually cure your sleep apnea. We often recommend retesting people at that time to see if they have residual sleep apnea. It most likely will make the severity way less, but it may not cure your sleep apnea.
And we've seen that in our practice. We've had patients who've lost a lot of weight and their sleep apnea did not go away.
Right.
Mm-hmm. And that's what drives me nuts, I guess. I have a few patients out there who they assume because they lost weight that they no longer need to use the machine. And when I say, oh, why don't we go ahead and retest you? They're not interested. Yeah. And I'm like, well, it's, not treating sleep apnea can be so harmful to other, putting you at risk for other chronic conditions, such as heart disease, heart attack, stroke, blood pressure. I mean, you name it. It's just, there's so much that goes in tune with sleep. We know we're very preventive, and for longevity medicine, like for a longer health span, right? Not just living longer, but quality of life for longer. Sleep is critical.
Yeah. So I think one of the most interesting things for me in the world of sleep is that we know that obstructive sleep apnea is related to all of these cardiovascular comorbidities, but we really don't know for certain if treating obstructive sleep apnea will prevent you from having a myocardial infarction or a stroke. Right. We think that it will. There's some pretty good data that on the more severe end of the obstructive sleep apnea scale, so an AHI greater than 30, that's where the greatest benefit of being treated. But in the mild to moderate range, there's a lot of gray area. A lot of that has to do with the gold standard of research, the randomized control trial. A lot of them have not been done in obstructive sleep apnea. The reason being is we know that treating sleep apnea does two things, okay? It reduces daytime sleepiness, which can later lead to reduced car crashes and workplace accidents, and it reduces blood pressure, okay? So you can't ethically withhold a treatment from someone that will make them less sleepy and prevent them from having a car accident. So you can never have a control group that has severe sleep apnea and is not treated with CPAP and compare it to another group that has severe sleep apnea and is treated. So a lot of the data is from retrospective analysis, from systematic reviews, and we think that there's pretty good data to suggest that treating severe obstructive sleep apnea will prevent cardiovascular comorbidities, but there's a huge gray area in the mild to moderate range.
One thing I've never understood is why all truck drivers, pilots, people who, bus drivers are not made to have sleep studies, because the risk has to be high.
Right. So in my fellowship, actually, we did a lot of the workplace testing, mostly for pilots, but there are some truck drivers. There's something called a maintenance of wakefulness test, which essentially you have to sit in a chair for an extended period of time and you can't fall asleep. If you fall asleep, you fail that test. So it's pretty interesting to actually test these people.
How long is the test?
I think it's upwards of 8 hours.
Wow.
Yeah, you don't have to sit there the whole time, but you do.
I was like,
no.
I couldn't do that just because of ADHD. Oh, wow. I have a hard enough time sitting in this chair. So, I wanted to ask, I had another question and that just threw me out. I forgot now. What was it? I think of something.
So I've had so many patients in my career who said, no, I can't wear a CPAP machine. I'll never be able to sleep with someone like that, who've come back a month later and say, that changed my life. I will never go anywhere without my machine. I've had the opposite too, but at the same time, a lot of people don't realize what a difference it makes to actually get decent sleep.
Right. And that's where I think the struggle is they start out you wearing it for like an hour and they're like, I ripped it off. I'm like, keep going. Then it's 2 hours, then it's 4 hours and 6 hours. And I'm so proud of them for wearing it for majority of the night because I know that at least if they can wear it for that 6 hours, it's getting into that REM cycle, and we know we get a lot of the deep sleep in the beginning stages of our night, the first few hours. And I just know the quality is there. And, and what I was going to say is I remembered, Alzheimer's. Do you see any link or are there any studies out there that show there's a link with like sleep apnea and memory loss or Alzheimer's?
So sleep, we classically think of sleep as a passive process where we're not doing anything for 8 hours. But sleep is actually a very active process. And especially in REM sleep, your mind is extremely active and it's cleaning synapses. It's getting rid of waste products. It's forming memories that are useful to you and getting rid of memories that aren't useful to you. So sleep is a very active process, and it's healing your brain and it's rewiring your synapses in order to make meaningful connections. So when you think about obstructive sleep apnea, when someone's waking up 40 times an hour, you're not having that consistent sleep to do all of these things, and it can cause very poor brain health, and especially if obstructive sleep apnea is not treated for years or decades.
Mm-hmm.
Wow.
So we know REM sleep is important. How important is deep sleep?
Deep sleep is our recovery sleep. So there's a lot of data to suggest that after a period, an arbitrary period, name it weeks, of sleep deprivation, the first night that you can sleep after a long period of sleep deprivation, you'll have a lot of your N3 sleep, which is our deepest sleep. We think of it as our recovery sleep, okay?
And do you know, are there any treatments for people who don't get deep sleep or who don't get REM sleep?
There are no treatments that I'm aware of. A lot of our sleep aids will actually alter the different composition of our deep sleep. You'll get actually a lot more light sleep and you won't get any of that deep recovery sleep. But as far as I'm aware, there aren't any treatments to improve deep sleep aside from a good sleep-wake cycle and helping to treat obstructive sleep apnea.
And you hit on something very important because I have a lot of patients who believe that if they take a sleeping pill, that they'll get more deep sleep and get more REM sleep, and they come back with their data, and it's worse if anything.
And another common medication that will alter the composition of the different stages of sleep we are is the SSRIs, the antidepressants as well.
Yeah. Well, I think this has been very, very informative. Thank you so much for coming on. But I would love for you to close this out by letting us know if somebody is thinking that they could have sleep apnea, what do you suggest they do?
I think the first thing you could do is talk to your primary care doctor about it. I think there's emerging data right now to suggest that maybe the reason that treating sleep apnea does not prevent cardiovascular morbidity and mortality is that we're catching it too late. By then, all of your vascular remodeling has happened. You've had damage to the microvessels in your body, and then you're at risk for cardiovascular morbidity and mortality that can't be reversed. So I would just say if you're sleeping poorly, if you're tired during the day, if you're falling asleep all the time, the best thing you could do is talk to your primary care doctor, because catching this early and treating it early is probably going to be the thing that saves your life.
And there's no lower or upper age limit, right, to test for sleep apnea?
No, if you're 18 years old and you're having trouble sleeping, I would certainly talk to your doctor about being tested.
Wonderful. Thank you so much for coming on.
No problem. Thank you.
It's been great.
Me. I appreciate it.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.